everyone to the October 8th, 2020 COVID-19 clinical rounds focused on preparing the ED for flu and COVID-19. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 emergency department challenges and successes. If I'm preparing my emergency department for COVID-19 patients and the flu, the clinicians I want to learn from are those with experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations who have collaborated on these rounds. I do want to recognize an organization that joined us as a collaborator, the American Ambulance Association, who joined just 2 days ago as a collaborator for these rounds. These rounds are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on healthcare providers sharing their successes and challenges with other healthcare providers. Thanks to Project ECHO, Dr. Bruce Struminger and his magnificent team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern. Next week will be just a bit different from our usual weekly schedule. Next Monday's EMS rounds are canceled. While indeed it's a holiday, more importantly, if you're not scheduled to do a shift, you take the time off. And if you are scheduled to do a shift, you make sure somebody's picking up another one for you later. It's really important for us all to take care of our mental health and fight fatigue and complacency. So next Monday's EMS rounds are canceled. Next Tuesday's critical care rounds will focus on use of a fairgrounds for surge, with our speaker being from Wisconsin. Next Thursday will be emergency department rounds. Thanks to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. These ECHO clinical rounds and NETEC's webinars are complementary to each other. I'd like now to turn this over to Dr. Bruce Struminger from Project ECHO.
Thank you, Rick, and welcome everyone. And welcome in particular to Paula, who's going to be presenting today. And actually, Wes, could you give me co-hosting privileges so I can share my screen?
Good to go.
All right, thank you. So just a few of the usual logistic items. We really appreciate all your questions and comments, so please share them with us in the Q&A function in the bottom of the Zoom toolbar. We'll be monitoring that Q&A area and hope to get to as many of your questions as we can. If you have any technical or logistic issues, go ahead and put those in the chat function and we'll look for those there. We are recording this session and your attendance is consent to be recorded, so thank you for that. Today's presentation, the PowerPoint, should be linked to the announcement that went out this morning. We will also share it on our website, the HHS ASPR Clinical Rounds website, and we'll share a link to that. It should be up within a couple of days, along with the link to the recording of the session. For those who would like CME and continuing professional development credit, we really encourage you to take advantage of that. We offer it through the University of New Mexico, where Project ECHO is based. We'll put a link in the chat about 15 minutes before the end of the session, and there should be a link in the email announcement that went out today. You have about 48 hours to complete that. We really appreciate and rely on the feedback you give us in the survey that you take before you get the instant CPD. So please keep that coming. Just want to remind everyone that these learning sessions are focused on improving patient care and health systems and supporting clinicians. So let's keep them apolitical and non-commercial. Thank you for that. Just a reminder about how the data that you share with us is stewarded. We're very careful and conscious of data stewardship and keeping it confidential. What data we do share with Rick and Asper is all de-identified. As many of you know, NETEC is a partner in this clinical rounds series, and they have a fabulous series of webinars, many of which complement topics that are discussed here in the clinical rounds. On Friday, the 16th of October is the next of NETEC's webinars. It will focus on pediatric perspectives during the pandemic. And there's a fabulous archive of prior recordings. The AAMC is also a partner in these clinical rounds, and they have been curating and updating a wonderful clinical guidance repository. So we just want to remind everyone of that and encourage you to go there for resources. And we'll share links to those in the chat. With that, Rick, back to you for the crowdsourcing question.
And before I actually state this, what you're seeing, or ask this question, I want to comment really briefly on Dr. Struminger's note to work on trying to keep these apolitical. It's been really extraordinary, given we've done between 75 and 80 sessions, I've lost count, how we really have remained focused on the patient and clinical operations and care of our fellow healthcare providers and ourselves. And your being able to hang on to that and not go into a political realm has been extraordinarily gratifying over the past sessions. So I really do want to recognize that we're in an extraordinary time in our history, and not just healthcare, but our country and world's history, and really do appreciate people remaining focused, because we could go off on a lot of tangents and we haven't. So thank you for that. So the crowdsourcing question. How has your organization prepared for flu and COVID-19? And you know, some of the answers would not be unexpected, that we haven't really thought too much about that yet. That's just fine. And you know, sometimes responses like that are at least as informative as, well, we've done this, this, and this. So, and I think that's just fine. With that, I'm really pleased to welcome back Paula Fessler. And when we started rounds, we started with the critical care, then went very quickly over to the emergency department, and then an EMS series. And as we did the emergency department series, what came very quickly apparent, based on comments seen in the chat and some of the questions, and then the breakout in terms of who our audience is, that nursing, and any emergency physician knows this. Those nurses save so many patients. Yeah, not just saved me, but so many of my patients personally, I can't tell you. And it was critical to have them. And Paul, I believe, was our first nurse who spoke on our emergency department rounds. So it's indeed a real pleasure to have her back. Paula is Chief Nurse Executive, Senior Vice President of Patient Care Services at Westchester Medical Center. Paula, welcome back.
Thank you very much. Good morning. I appreciate the invitation, and I'm currently Chief Nurse up at Westchester Medical Center. I'm also the Secretary Treasurer for AENP, for American Academy of Emergency Nurse Practitioners. We saw COVID. We're about 10 miles from patient zero in New Rochelle. Our max during our peak, which started, our first patient was diagnosed in-house with a confirmed test on March 13th. Our max number of patients in-house at one point was 224 patients. We are licensed for 73 ICU beds, and on our heaviest ICU day, we had an additional 71 ICU patients. We created multiple ICUs. We moved into our ambulatory surgical center for our non-COVID ICU patients to be able to handle the surge that we went through. So I spoke back in May about kind of what we had just gone through. And today I'm going to be sharing a little bit about how we're preparing today for our current environment, which is significantly better. But now ED and with the COVID and COVID and flu. So with that, I'll go ahead and start my presentation.
Absolutely, please.
Thank you. So let's see. So COVID-19 and the flu. One thing I think that was just really important that I wanted to share, we're actually still treating every single patient when they come in as a COVID-19 patient. Currently, our community positive rate is around 1%. We have pockets where it's creeping up in a couple of counties around us, but we have never, ever, ever gone to a area of feeling like they're not a potential COVID patient coming in. So ED and beyond, absolutely everyone gets a mask. It's every patient if they're moving through the hallways, every designated support person if they're in visiting, all staff everywhere in every one of our buildings still wears a mask. And then every single patient coming in that's admitted to our hospital gets a test. It's up to now, it's been a COVID test. We are now adding flu A and flu B for every adult admission, and every pediatric patient gets tested for COVID, flu A, flu B, and RSV. From an infection control perspective, all of our ED staff are still in N95. That is our required mask for providing care to anyone with COVID-19. And since all of our ED patients are undifferentiated, they're in N95 safety goggles and gloves. And then if it's a known negative COVID patient, we're still wearing a procedure mask, safety goggles, and gloves just for the added protection. And then the other piece that I think has always been super important, and Dr. Schneider and I, this has been a passion of ours since a long time ago, but ED throughput is truly the key to keeping the ED decompressed and ready for our next patient. Our goal is to have patients out of the ED once it's been decided to admit them within an hour. We're not to our goal, but we are well on our way to meeting it. And we actually did better during our peak COVID time because we just had unlimited number of patients coming in. So it was really, truly fantastic. While there's so many moving parts to move a patient out, it was absolutely critical during our surge that we had usually twice daily calls on operations between patient placement, our physician teams, and nursing to be able to get those patients out of the ED. In addition, ED discharge, when we were sending patients home with COVID that may have otherwise sometimes been admitted, but because we were so full, we were sending patients home that might have had a little lower oxygen level, we started doing follow-up wellness calls to all those ED discharges. And that made a significant impact to us feeling more comfortable with sending them home and making sure the patient was still doing well the next day. As far as COVID-19 and the flu, the one thing that we've continued since we started preparing for COVID at the end of January last year was cross-training so that we could do team nursing. We were really fortunate, I'll say fortunate, but we really, New York State, we stopped doing elective surgeries. We had to. We actually started significantly cutting back. Patients chose to cancel elective surgeries, and we stopped surgeries before New York State made us. We were able to redeploy probably close to 150 RNs from other areas, such as peri-op, PACU, IR, cath lab, advanced practice, outpatient areas, and our pediatric hospital was actually very low in census. And we were able to redeploy many of those nurses as team nurses to do support services. And if they had competencies, take assignments both in adult med surg and ICU. I am 100% confident that the only way we were able to meet our needs this spring is because of our team nursing concept. Our physicians did very similar items as well. We had multiple groups of physicians pick up and help take care of our ICU patients. In addition, we worked with our frontline leaders, staff, and union leadership to really set expectations and goals. This spring was very much learn as we go, do as we need, because our needs kept increasing. And we've really worked diligently over the last several months to make sure that we start to hardwire that a little better. And then the other thing that's really, if you're going to make lemonade out of lemons, with our COVID experience was we started hosting multidisciplinary operations meetings in many of our units across the campus. And we had that as an informal, but we're really looking to formalize that and make sure that every voice is heard when we're talking about issues at the unit level. As far as where we are today, I think supporting staff is the thing that's changed a little bit, still very much there. But when I spoke back in May, I talked a lot about the uncertainty and fear. And when I was rounding, as our numbers were first beginning to go up, staff, everyone was very much afraid. What if I get this? We didn't know how contagious it would be. We had donning and doffing coaches outside rooms. I will tell you now, at least in our environment, the fear of getting the illness is a lot less. Our infection rate among our staff was at or below our community infection rate. Our nurses, who had the most exposure, were below the community infection rate, which was absolutely fantastic. We know PPE works. So that fear in of itself is definitely different and much less than what it was. The fear today, when I go out and around on our units, the fear is actually of another surge or having overcapacity. And I had one nurse when I was rounding, actually, we have one COVID floor right now that's really cycling. Every patient comes in as a PUI. They go to that floor first until they're ruled out so that we make sure we keep any positive patients cohorted. But a nurse on that floor said to me, she said, I don't know if I can do that again. So I know there's a couple of questions, and when we get to questions and answers talking about how do you support staff, wanted to certainly call out that we started a staff hotline during COVID, and that hotline is still available today, and it's our psychiatry team that will be available anytime if a staff member needs to call. We also have a very active chaplaincy program. We started posting chaplaincy rounds so that staff know when they're going to be coming through the unit. And our chaplains are not only rounding to be with our patients and to be present with them and their designated support people, but also to be present with our teams and our staff members. And then the other piece that's really, for any of us that still have school-age children, home routines are not routine right now. Many of the schools around our area in New York, they went back in hybrid modes. They're half virtual and half on campus. Some are half days, some are full day, but almost nothing is normal. And then just announced last week, several New York City schools have been closed in areas where we're seeing a small rise. So that all adds to the stress that we see at work because we don't have routines that are predictable at home. With the school closures last week, we actually had several nurses that asked if they could adjust schedules. And we are doing whatever we can to partner to make sure that we meet those needs because that actually helps us meet our staffing needs and, of course, our patient needs. Another piece of the uncertainty from before is PPE. I'm really excited to share that our system has over a 90-day supply based on our max use during our peak back in the spring. But managing that PPE supply is definitely a little bit of a challenge. It needs to be available, but it also needs to be secure so that it doesn't walk out the door. And lastly, as far as supporting staff on this page, sharing our COVID numbers. Our staff, they want to know where we are. They want to know how things are. They certainly hear the news when there's a little bump up in a community. Is that impacting us? Do I need to be worried? I'm really thrilled to share that over the last several weeks, we've had less than 10 COVID patients. However, we have had our first flu positive patient. So the topic of today's conversation is definitely we're gearing up. Additional stuff with regard to supporting staff. After our peak was coming down at the end of May and all through June, I actually debriefed with all of our patient care units, with our respiratory care providers, our nurse educators, other leaders, and even with our chief residents across the campus. We wanted to know what worked well, what needed to be improved or changed, and what worked well, just in case anyone's still going through it. The feedback was really fantastic to have the support team. So we would have a nurse in the room with full PPE on, and we'd have another nurse, maybe from another area, from peri-op, that was outside. They had their PPE on to be on the unit, but they would be the one running back and forth to the med room or supplies and really work to help and assist the nurse that was inside the room. We use scribes. So if a provider was inside a room, they would actually be scribing to somebody outside the room so that we could decrease any sort of contamination and be as efficient as possible. We had hypoxia teams that actually went out, and it was our pain service team. They were truly fantastic. They would go out and they were the ones doing assessments on our patients that were on the floor and help to really troubleshoot and support the medicine teams if we had patients that looked like they were having increasing needs. And then lastly, a prone team. The prone team initially was put together to help prone our ICU patients. And we quickly learned that proning patients in the med surg area, which most of them could do on their own, but that was a really effective treatment for us to help us give, I think, more robust care to our patients. Another topic that really was a huge win, and this would be for COVID or flu patients, was clustering the care. So instead of having a nurse go in a room every hour to do something, we really tried to make sure that orders and meds could be given so at the same time, so the nurse could go in, do clustered care, and then come out for a couple of hours and be able to assess the patient on the other side of the window. Communication between teams and families was also something we really struggled with at first. We restricted and had full restriction of visitors. I can't remember the date, but New York State actually came out and DOH restricted visitors as well. It seemed like the right thing to do. Our community infection rate at testing was almost at 40% at one point. But we found the communication between the teams when you don't have a family member at the bedside was really challenging. So we started doing phone calls to families if it was what the patient wanted or their proxy wanted 3 times a day. Each nursing shift, a nurse would call, and then 1 time a day, a provider would call unless there was a change. That significantly and still has had impact. We have fewer complaints about communication today than we did before COVID. Telehealth was a really phenomenal success. We had used it a little bit in a limited fashion for outpatient. That has completely increased, but we use it really a ton more with the inpatient and COVID positive patients. We have them linked to both their provider and physician so that we can increase communication between the rooms and the staff. And then we have fast testing. Depending on availability, we have changed our testing platforms, but being able to have a fast turnaround has been really key to be able to decompress the ED and get patients on the right floor for the right care that they need with the right PPE for our staff. With regard to testing, we're currently using different tests for COVID and flu, but we are anticipating in November to be able to have a multiplex test that will cover all of those needs in one test. As far as what needed to be improved or changed that I learned on our debrief sessions, the PPE distribution, while it was present, wasn't always easy to access or ready when you need it. So we've been looking at how do we redistribute that so that it's secure but available. In addition, from a biomed standpoint, whether it was HEPA filters or cooling blankets, when we have the resources, and we had enough resources, but how do we distribute them and manage them? When we had rooms with patients that never had rooms and patients before, that got a little bit confusing. So we've got some committees doing work right now to make sure that that's more streamlined should our need and surge go back up. A really wonderful thing that seems really simple but could be a huge impact, we needed larger trash cans. Trash cans were overflowing, and it makes a huge difference to the room and also our staff and the number of times they need to go in. So those were some easy wins to fix. And then the last piece, because we did have staff move around and float, was to standardize on our supplies on the different units, so that if you went from one unit to another unit, you could find the new PPE that we added to all the floors, such as our safety goggles. And then lastly, next steps from the debriefs, in addition to communicating with town halls, the lessons learned, we put together some multidisciplinary committees that include attendings, residents, nursing, respiratory therapy, and how do we address some of these issues that are outstanding. And we also have one other committee that we've put together that's about work-life balance, knowing that this has been a very long stretch for us. This started at the end of January in our prep, and we are, I don't see an end yet. This is something that we're going to continue to deal with for several months. Lessons learned, this is actually from my side back in May, because I think it's still really important. From a leadership, at least from a nursing leadership, you can't lead from home. You do need to be present. You need to acknowledge the fear and build trust. You need to listen and share stories. That's a wonderful part of what healthcare providers do. And then we celebrated victories. So when we had patients, and we had some really hard days, but we played a song throughout the hospital when patients with COVID were discharged, as long as they were in agreement with that. And it was really, truly fantastic. And even the patients that, the ICU patients who didn't see their patients walk out got to participate and celebrate in the victories as well. And then from a planning perspective with moving forward, my advice is get to where you want to go. We did a lot of room changes. We opened up a 5-bed unit to be our COVID unit, which in 5 days we outgrew. Plan, if you're seeing a wave, plan to be able to go big so that you don't have multiple moves. Those were definitely stressful. And then continue to cross-train and maintain your competencies of all your staff. For example, all my nursing leaders have been trained and are expected to maintain their competencies so that they can step in and take a patient assignment. It's great to be support, but if you can take a patient when somebody else is really in need of help, that's the right thing for us to do. And that's my presentation for today. I'd certainly welcome questions and dialogue. And I also know that there's some questions that were pre-shared. So Dr. Hunt, I'll send it back to you and we'll go from there.
Yeah, thanks very much. In terms of like, well, I've got a couple questions that are from our participants, and then we had questions in pre-registration or during the registration process. And as those, that happens every time you register, you get a question about like, what's the most important issue and so forth. And over the past few months, those questions have remained a broad range of kinds of questions. All the way from like, what's next to like, give me like the biochemistry around remdesivir, or it is a huge range of questions. So in terms of questions that we've seen from participants already today, Paula, the question here is, how do you enforce social distancing and masking at the nurses station? Our staff are getting lax and seeing positives in our staff. And you may or may not be having that as a challenge at your institution, but how would you address it?
So we actually haven't had that as a major issue. Little pockets. Every now and then you need to remind somebody. We just say mask up. Most of the time it's, maybe the mask is under the nose or just below the chin. We actually, initially, we removed all furniture from our cafeteria and from our lobby. We didn't want people to congregate. And one of the feedback, actually, it was from one of our nursing union meetings, was, if every chair is gone, then many of us are sitting in a very small space, unmasked and eating on a break. So we have actually redeployed 1 or 2 chairs per table. Certainly it's a pretty frequent reminder that you absolutely need your social distance or physical distance if you take your mask down. But obviously, if you're here for a 12-hour shift, you have to go somewhere and eat. But it truly has been not difficult. And most people are very receptive if they need a little reminder. And all of our guests in the building, whether it's a vendor or facilities or a designated support person, everybody has to wear a mask. So it's really unusual to see someone without a mask, and it's usually corrected quite easily.
Yeah, thanks, Paula. And over the past few months, we've had a number of either chat or comments made about break rooms being particularly vulnerable spots, with people letting their guard down in break rooms too. So just wanted to mention that. Another question, and this one we've talked about this actually months ago during peak surges, the peak surge period. The question is, what about staff that test positive? And what precautions are you using, and when may they return? And we have all evolved with this. So where is it today for your institution, Paula?
So we still have the same rules that we've had since mid-peak. Every staff member, and actually anyone entering our building, has to take their temperature coming in. It's a requirement that you have your temperature and have negative symptoms before you even swipe in at work. We don't want you here if you're sick. That is definitely an added complexity when you have increasing patients and you're not sure who's going to show up. So that was definitely part of our challenge early on during our peak. We've had about 134 nurses that were positive. It was about 8% of our workforce on this campus, which was less than our community risk and community exposure. If somebody has symptoms or a fever, they must be tested. They cannot come back to work until they're tested. And then if they're positive, they're out a minimum of 10 days. They have to be cleared through Health to be able to come back. And if they're negative and they're still having symptoms, it's still a dialogue with occupational health before they're allowed to come back to work.
Thanks, Paula. I've got a question from Sandy, and for all of our panelists, first of all, thank you for joining us. And when you make a comment or a question, if you could please quickly introduce yourselves before you ask or provide comment. After Sandy's question, I'm going to go, panelists, you'll still have your shots here, okay? I'm going to go to the polls and get a sense of what's going on in the nation around a lot of the flu issues. So, and then we'll come back to the panel. So Sandy, please.
Yeah, so I'm sure Paula knew this question was coming. As usual, I watch like a 20-minute presentation and I pick up on one line. And given our history and crowding and the institutions we've worked in the past, how do you get patients out of the emergency department in 1 hour? What does it take? Because I think you might be the only place I know of right now that's able to be done. And then I have a follow-up.
Sure. So we're not at an hour. That's our goal. Full disclosure. It is significantly better than it was when I arrived here 2 years ago. But the biggest thing right now is the challenge with waiting for the COVID test. We originally used Cepheid. We had results within 2 hours. We still get a limited number of Cepheid, so those tests get prioritized to anyone that's a level 1 trauma that's potentially going to the OR. We still have an OR that's COVID positive for COVID positive patients only. And then any psychiatric patient, and I realize that's one of our questions here, any psych patient that's requiring admission, they also get a Cepheid test so that if they're negative, we can get them where they need to go for their care. During our peak, we actually had a psych unit that we opened that was for COVID positive patients. We were the only one in the area. And we had can't remember, I want to say probably between 8 and 10 patients in that unit during our peak. That has not been a huge issue lately. But again, we are screening all of them. And in order to do it, Sandy, it truly, right now, what we're doing, because our testing is taking about 8 to 12 hours. We're using a Roche platform for any regular admission that doesn't have an urgent need to have an answer. So we've opened up a floor that takes all the PUIs. So any patient that's coming in, if it's a medicine patient or surgical patient, they're all going to one unit, and that's where they'll go get their initial workup started. And so we differentiate where they can go. We have one whole floor in the hospital that's actually only for immunocompromised patients, and they can only go there if they're negative. So it's a work in progress. It's a little extra movement, but it is helping keep the ED decompressed.
I just give you a major round of applause, and I understand probably why this was a high priority with you, given us, but I think this is something that all hospitals need to address. And I am particularly concerned about infection control in the emergency department. We have incredible things going on inpatient. You've got COVID units, you've got PUI units. We have good infection control in the outpatient clinics. With social distancing, etc. The emergency department in many places, and I'm not going to name names, but in many places have been left out of that conversation. And I think that that's a real disservice to not only the staff in the ED, but more importantly, the patients. I don't know if you have a comment on that. But Dan looks like he has one.
Yeah, Dan, please quickly introduce yourself and then comment question. Then we need to go to the polls. Thank you, Dan.
Yeah, hi, Dan Gerard, IAEMSC. Great presentation. 2 quick questions. One, did you see an increase of children with multi-inflammatory syndrome? And the second one is, how are you going to rethink your PPE stocking and strategies? Many hospitals and medical centers used to use just-in-time ordering for supplies previously in the past, and I'm sure you're probably going to look at this a little bit differently. Thank you.
Of course, thank you for the question. I think we've seen about 30 pediatric patients with the multi-inflammatory syndrome. For the most part, they've actually done very well, but it's obviously it's still on the radar. It was not nearly as stressful handling that population compared to our surge on the adult side. And then we saw very few admissions actually for children with COVID. So that's still unfolding. As far as the PPE, New York State has actually mandated to the Department of Health that we have 90 days on stock, in stock for our peak days, and we are there. Actually, the challenge to that is where to store it, because 90 days of PPE is a lot of PPE. So it is stored, and we do have it available. But we started ordering once we knew. We started ordering in December and January, and we definitely had unreliable shipments during the peak. And I believe our shipments have gone back to pretty much our baseline, but we'll continue to stockpile.
Thank you.
Thanks very much, all. Wes and Amy, if we could not quite hit like the poll, I want to say just a couple of words about the poll before we put it up, but be primed to do that. So for participants who, because panelists and speakers can't participate in the poll, but your participation in the poll has far more meaning and value and importance than you might otherwise imagine. While we get to see this, the poll results in real time, we also talk about, yes, we shared at HHS, and I'm going to give you a very specific how that actually has plays out. We did a special combined all rounds on last Thursday on remdesivir and dexamethasone. This afternoon, I'm presenting to the Interagency Healthcare Resilience Work Group across HHS. It also involves, for instance, DOT's Office of EMS and FDA and on, presenting those polling results from last Thursday session. And in addition to that, some key points that were made actually on economics by our panelist, Dr. Cunningham, and also key points made about the challenges clinicians have in this like once in a century experience of way too much information and research to be able to figure out how to actually absorb that and figure out what to do for the patient, given the volumes and a sort of a rapid approach to synthesizing and that information, not just digestible, but being able to create protocols in real time. So I want to let you know what happens on these rounds actually have far more impact than you might imagine in this 1 hour. So with that, if Wes, Amy, if you could put up the polling, there's about, I think this will take about 10 minutes. There are about 10 questions, something like that. And some of them are really straightforward, easy to the point. Some of them are sort of like lengthy, multiple options. So just hang in there. We'll get through these and we'll see the responses in real time. So Amy and Wes, we can put them up. There we go. In your emergency department, are all patients required to wear masks in the waiting room? That's pretty straightforward. Hey, look at this. 41% have already voted. Just awesome. Give it about 10 more seconds. All right, let's stop there. And so trying to explain to the HHS work group about these polling results. And like, there are a lot of people that actually don't work in the emergency department or work in critical care. It's complicated, but you see the results here. I mean, only 1% says don't know and no 0. So that's actually, I think, pretty gratifying. Next. That's the same question. Can we go to the next one? Here we go. I have already gotten my flu shot, plan to, don't plan to. While I can't actually like respond to these polls, I actually I didn't get my flu shot a couple weeks ago. Yeah, Sandy did too. Great. Yeah, left arm for me too. We got 71% voted. Let's keep going, okay? I really want to see what we can do here in terms of like getting these like, and by the way, people are stunned at like, you get that kind of response. So really proud of our participants. And no, we do not identify individuals in your responses. Bruce said that up at the front end, but I want to like reinforce that one, okay? All right, let's stop there. 74% of you voted. 59% have, 35% said plan to, and 6% said don't plan to. Next. Flu shots for staff in my organization are required, voluntary, don't know. I think I've probably seen about 30 papers on this in my career over the years. 70% have voted, another 5 seconds. All right, let's stop there. I had no expectations at all for this one. I had no idea how this was going to play. Interesting. All right, next. Okay, so which are the following? This one we're gonna have to leave up for a while because it's like you can select all that apply. So which of the following are reasons you've heard from healthcare providers for their not getting a flu shot? Wow, lots of responses quickly. In the chat, I see someone indicated it didn't hurt when I got they got the flu shot. It didn't hurt. I mean, honestly, this one for me personally, compared to other ones, not only did it like not hurt, I mean, like for like 0.2 seconds, but I didn't have like the soreness thing. That's just me. And I'm not like doing an advertisement for it. I'm just like letting you know it really didn't. I mean, it's like, how about that? That was cool. We got 67%. I'll wait another like 10 seconds or so. All right, let's stop there. 70% of you voted. That really helpful information. It looks as if the most frequent ones, 51%, I'll have side effects, and 50%, I've never gotten the flu before without a flu shot. Other high responses, frequency of response, I'll get the flu. It would be, just as a total aside, it would be interesting to see how, you know, our responses to this, if you did this for the general population, how that might compare. Interesting. All right. Next. Which of the following do you believe are most likely to get flu shots? Yeah, this is just a single response. We had 67% voted. You know, this is like your opinion. So you get an opinion. Everybody has opinions. So it's like, I didn't have a not applicable here. All right, 70% voted. Let's stop there. The most frequent response was nurses, by far. Go nursing. All right, I leave it up for a second. I've seen it, but many haven't seen it. All right, let's do the next one. Similar question with one word replaced. Which of the following do you believe are least likely to get flu shots? And what's, for awareness, when we get the reports of, you know, from ECHO, compiles the information about your discipline and so forth, so on, and it's a really broad range, but there's a pretty equal split out, or frequently an equal split out among nursing physicians, EMTs, paramedics, with some respiratory therapists, some epidemiologists, some veterinarians, sometimes some other disciplines, but it's basically those sort of like three clubs: EMS clinicians, physicians, and nurses. There's 64% of you voted. I want to see if we can get that bumped up a little bit before we finish. All right, I think we got diminishing returns here. 66% of you voted. Let's show this. Looks like the most frequent was lab X-ray staff, then physicians, then EMTs. Interesting. All right, let's do the next one. This is, so if you don't work in an EMS organization, there's the option at the bottom for that one. Don't work in an EMS organization. But our organization's EMS organization staff do not administer flu shots, are trained, are administering, don't know. All right, let's stop there. 68% of you voted. And 33% do not administer flu shots. 13% are. On the EMS rounds, there's been, which are Mondays, except for next Monday, we've had some discussion around administering flu shots. Fascinating to see those results. All right, thank you. Next. All right, there's just this one and one last one. Patients have presented to our emergency department with presumptive influenza with confirmed flu, no presumptive or confirmed patients, not sure. Or you're not in the emergency department. About 5 more seconds. All right, let's stop there. None, 14%, and then with presumptive influenza, 12%. And then 7% with confirmed flu, 7%. Leave it up for a second. All right, let's stop there. And I think one last one, maybe. Yeah, okay. As of today, October 8th, our region has experienced no flu, some flu, a lot of flu. All right, let's stop with 69% have voted. 36% with some flu. And 28% with none yet. It's pretty striking. All right, well, let's stop there. And I'm going to turn this now over to our panel for questions, comments, and I think I'll just go around by name. Dan, or actually, Harry, I just saw you pop up. I'll let you I'll just go around by name. Harry?
I just wanted to thank Paula for a great talk, and these are pretty important points as we move into a new season here. Responding to one of the questions in the Q&A, we've started hearing information from the Southern Hemisphere that we believe this may be a mild flu season. I'm really worried that we need to guard against oversimplification of the problem and confidence that that's the way it's going to roll in the Northern Hemisphere. I think this is going to be an exceptionally complicated season. Rest when you can so that we can be on our guard and we continue to have these sessions here because these are our best sources of information, I think, and information is our friend and our ally as we're trying to get the message out not only to our patients but to our coworkers and our employees in our hospitals and EMS services.
Thanks, Harry. Appreciate that. Dan? And I'll go to Dave, Sandy, Carol. And then Paul, you get the last one.
Thank you. all the things that I've learned from Project Echo, and I've learned so much over this period of time, and especially with Paula's presentation today, is that we are truly more inclusive systems of care than exclusive systems of care. And it's really everything that we do across the continuum, working together in concert with one another, that will truly achieve great success. Paula, great job. Thank you.
Thanks, Dan. Dave.
Yeah, Paul, this was wonderful. I just have a question for you, though. You know, you talked about your throughput abilities. Usually that's a problem because of lack of staff upstairs, not necessarily in the emergency department. Have you had to use travelers or a lot of overtime, or how have you addressed that staffing problem upstairs to get those patients moving?
So historically, they've used travelers at our institution, and have been working to drive that down. I think nothing replaces having your own staff, that just people know people. And once you have a relationship, it's easier to pick up a phone and say, hey, I really need you to help out. I will tell you, the travelers we had during our peak in COVID, they all left. Every single one of them left because they went and got paid more in New York City, which is only 20 miles from us. So truly, it was the team nursing that allowed us to do what we did. We're currently upping our agency just a little bit because we're going on a new EMR next week, because we couldn't have enough fun with just COVID in a year. So so we do have travelers, we do use them, but truly it's more about the relationship and the expectation, and being able to set that as an expectation. There was never an expectation before. We often had a bed, and we might have even had a nurse, but if someone isn't pushing, they weren't going anywhere. So it's really been, in particular on off shift, our nursing supervisors, they're responsible for the flow for the whole building. It's not just a matter of covering an emergency. So setting those expectations and then having really candid conversations about what needs to happen. So ED, 15 years, you can't take that out of me, and we need to be ready for those patients we don't know. They will be coming, so we need to be ready.
Thanks, Dave and Paula. Sandy.
Yeah, just a quick comment. And first off, thanks, Paula. As usual, you've done an absolutely marvelous job. I think you said something very important there. It's about relationships. It's about the relationship that we all have with our nursing team and our physician teams. And I think we should all really use that relationship and the relationship we have with our patients to urge them to get an influenza vaccine. I know there's some controversy around it. That's not nearly as much as there's going to be around COVID vaccine. I think particularly our older patients and our young patients really need to get that vaccine, and the ED and EMS is probably a way to provide that.
Thanks, Sandy. Carol?
Again, a great presentation, Paula. I was really struck by your slide that you're testing emissions for COVID, influenza, and RSV. All you have to do is look at the CDC website, and it tells you how many hospitalizations were due to influenza and deaths from last year, actually the past 2 years. And I also love the way that you're cross-training folks. I was surprised at the polls that more EMS agencies are not administering vaccines. In Ohio, EMS providers probably administer over 50% of them. I'm curious if this will open up a possibility where some staff, like you're cross-training your people to actually either screen people for whether they've not gotten a flu vaccine or Pneumovax in the ER, and possibly have an avenue, you know, through a fast track or wherever, where they can be immunized against that, again, to lower the bed crunch months from now. Particularly for those patients who don't have primary care physicians, and even those who do, who because of COVID can't get to see their primary care docs. But I applaud everything you've done. It's a nice model to follow. Thank you.
I was going to say, I have to tell you, we are very good about vaccinating our patients on discharge. I don't think we've talked about vaccinating our patients in the ED. I love that idea. So that'll be a takeaway that we could institute right away. We've been great with staff. We actually have we go through the alphabet. So if you're an A, you come on this date. And yet I will share our staff vaccination rate is lower than what I would expect. And the feedback we're getting from some staff is, I'm wearing a mask anyway. Why do I need the vaccine? So I do think there's a lot of education opportunity, but I love vaccinating ED patients for flu. And I don't know what we're doing. So I have a follow-up. Thank you for that.
And I don't know if your state allows it, but in Ohio, I even picture setting up an area with Ohio EMS providers, so it also reduces your staffing load. It's something that could be done.
Sure. That's great. Thank you.
Yeah, it seems as if there was a time to turn on innovative, well, when I say innovative, they're not particularly innovative. It's just like all the barriers have been there forever. Knock them down now. I mean, if we're like, it's a predictable surprise how this is going to play, and put it on afterburners to like make those barriers come down, and the ED one and the EMS vaccination provision. It's just like, really, or like, we just got to like make this happen. So yeah, whatever folks, not just in the panel, but participants can do to help break down those things and make them work, I think is going to serve us all well. Anyway, Paula, any last comment before you go?
No, other than just great appreciation for the panel. And I think this is the best of COVID from my experience has been the collaboration across multiple lines. Not only physicians and nurses, but even our patient care partners and respiratory lab. It takes all of us to get done and to care for our patients. And I've never seen it work this well in my entire career. So I thank you for the invitation to join again today, and really, really rally and am invigorated by what I've learned today from all of you. So thank you.
Thanks, Paula. And I got to tell you, Sandy was the one that really, Sandy and Vikram Mukherjee, who has presented and been a panelist on many of the critical care rounds, have both pointed out during the Hollywood Squares early on this, how the cross-discipline thing has really worked to patients and society's advantage. And I think back to, in particular, the first time we had, like, I couldn't believe we're doing rounds between long-term care and critical care, but how critical that was in terms of the long haul patients. And Sandy, the interface of the ED with the rest of the universe on both sides, outside and inside the hospital, being at the sort of like center of that universe, and the importance of us continuing this dialogue, not just continuing dialogue, but acting on some of it, I think is just like critical. In terms of the future of the rounds, we've talked quite a bit about that internally, but also with some leaders such as Sandy and AAMC and Project Echo. And, the virus isn't going away, and we just need to figure out how to right size these to make sure we're attentive to people's in support of their mental health fatigue and complacency, but also make sure there's a platform for this. So with that, I just thank you, forever grateful to our participants, our panelists, Project Echo and Paula, just like really insightful, and thanks for the dialogue. Anyway, we'll see you on the next one. Next Mondays is canceled EMS, and then Tuesday and Thursday we're back. So with that, bye.